If you want to know the three biggest mistakes physical therapists make with acute injuries, you have to tune into this episode. Uh, Hi, everyone. Welcome back to the podcast. Welcome, all new listeners, and welcome back to those who have heard my content in the past. If you want to know the three biggest mistakes physical therapists make with acute injuries, you have to tune into this episode. Before I go on to the podcast, what is new? What is better? All good things. I'm on the up and up relative to where I've been in the last 6 weeks. It has been an absolute grind, and I'm excited to see the light at the end of the tunnel. What is happening? So, my kids are doing great. My son Zach is loving jujitsu. I wasn't sure he was going to love it this much. And so he's really excited about he uses the word fight, but I think he enjoys the challenge, the strategy of seeing how people take down, or if he's on his back or doing a bridge, how do we get out of that? So I think he likes the strategy in that. My daughter's doing amazing, already telling me that she doesn't enjoy my yucky kisses anymore. My son Jacob is the king of the house and enjoying life. My wife and I are doing great. We're back to a fitness routine, which is great. Just coming off a very busy season. And I just finished up my accelerator course, which was fantastic. Thanks to everybody who joined over the weekend, virtual and in person. And that has been awesome because right off of that, I'll tell you about two additional courses that I'm hosting. Just off of conversations from that, we already started launching some new programs that we're doing for sports physical therapists all around the country. So I'll tell you more about that, but that's what's great. That's literally what's happening behind the scenes, and there's a lot of good things. So, all right, on to this podcast. We're talking about the biggest mistakes that PTs make with acute injury management. Why am I doing this podcast? And it's because of the conversations I literally just had over the weekend, and I realized sports physical therapists are different than ortho physical therapists, and what I mean by that is if you're an ortho PT and you see a couple athletes here and there, that's very different than being immersed and seeing not even professional athletes, but just more active people, right? Depending on your setting, but seeing on that on a regular basis and understanding their mindset and understanding what we can do and be able to help athletes at any given level. So I learned that, and I think that it doesn't matter how many years you've been practicing, you're probably going to come across some of these challenges, and how fast you overcome them will be not necessarily the skills that you have. It's just, will you make the same mistakes repeatedly, or will you address them a little sooner? And I have some feedback for you based on the feedback from the attendees. And a few of those things were really, really straightforward and simple. And I want you to be able to take this into your clinical practice and be able to implement this quickly. And I eventually want to be able to make an impact on this profession a few different ways. And the topics I'm going to bring up today are part of that. And I really think that if we can understand acute injury management and get people back to whatever they want to be able to get to, I think we have a role with being up there with urgent cares and primary care physicians from a musculoskeletal standpoint. I don't want to talk about meds. I don't want to talk about any other things. I just want to talk about musculoskeletal care. And as I went through this and I navigate, I'm going to give you some ideas wherever your respective community is. And if you can help these patients or athletes in these settings, you will put yourself in a position that you'll be able to help your community at a higher level than just being a um, uh, pain management physical therapist. And I'm going to share some things that will help you tremendously in your career. So here we go. All right. Number one. Uh, we as physical therapists see we see acute injury, and then we use the same philosophy that we would in orthopedic care. And at the start of this course, I asked the audience, I said, hey, what would you do for acute injuries for this, right? And everyone said their ideas. Well, and I said, what wouldn't you use? And some attendees provided that information. And by the end of the class, everybody was like, the things I wouldn't use, I should be using. And let me go through a couple things. Let me break this down. When we talk about acute injury management, there's three main phases that any athlete or a person goes through before they even come to see us in the clinic. And this is old school soft tissue healing. The first phase is the inflammatory phase. This is from 0 to 6 days or 4 to 6 days. This is where all that tissue repair is happening, right? So that's where you get the initial swelling, you get the redness, the ecchymosis, all the above. In that inflammatory phase, it's a very sensitive area that if you aggravate tissue, it can send them back and it delays their healing. The next phase after that is from 4 days to about 24 days, which is your proliferative phase. And there's overlap. It's not linear in this whole process. So at 4 to 6 days is where you have this overlap where now proliferation starts to happen. You have collagen coming in, you have scar tissue formation. And as you build this, there is a certain time point within the proliferative phase where you get the peak of proliferative, and that's around day 14. So the peak of inflammatory is around day 3, and the peak of proliferative is day 14. And now you have this descent of proliferative up until day 24. And after that, you have the remodeling phase, which starts around day 21. And that continues on. And if people develop chronic pain, they just go on for years, whatever, months, years, whatever it is. And with acute injury management, you kind of have to know your timelines and when you can most mess people up, because if you know your timeline, you know there's high risk at certain phases. And the highest phase is day 3. Second highest day is day 14, and the next highest day after that is probably going to be around your 21 to 24 mark. So at day 3, 14, and 21, you kind of have to make some decisions on what you're going to do for this person. Now, you can't aggravate them. And we went through research and we looked at a couple different cases for low back pain, for shoulder pain, knee pain, and ankle pain. And we looked at what are the kind of the most effective things to do. And a couple things were very surprising to some people that, I think manual therapy and exercise, that like, I think this is a no-brainer. It helps with acute injuries. I get that. But what do you do as a physical therapist if you can't touch it, if you can't like touch the body part because it's so inflamed, if you can barely even do soft tissue on it, right? What do you do? How do you help them? I posed a question: how are ortho physical therapists any different than urgent cares or primary cares who tell an athlete just rest for 2 weeks or 4 weeks or 6 weeks? I know at 4 weeks I can really start working on your tissue. At 2 weeks I know I really can start working on tissue, but from here to now, let's just leave it alone. And if you take that approach, you're wasting time. You're wasting the athlete's time and money. Now, what you want to do is you have to understand, you're right, you can't do a lot of progressive resistive exercise or a lot of soft tissue until probably day 14, maybe day 21. But what if the athlete has an event or something to get back to by week 3, 4, 5, 6? What you're doing is if you don't work on them, if you don't have a plan for them, what will happen is they will become deconditioned. They'll lose strength. They'll lose a little bit of muscle mass. And ultimately, by the time they're ready, or by the time it's 6 weeks, they're deconditioned, they've lost weight, but they're rehabbed. The body part's finally moving well. But what happens is you're slowing down their ability to be prepped as close to the event as possible. And instead, you worked on and you focused on the knee joint itself. And the primary purpose that you help people, especially during an acute injury management phase, is your goal is to be able to help them create a comprehensive program so that way they can still work on strengthening of their upper body, lower body, whatever it is, to be able to work on their energy system development. So working on cardiovascular work, intervals, anaerobic work, whatever that is, and then be able to work on practicing and any versions of that while they rehab the low back, the knee, or whatever it is. So that way, by the time the knee is healed, the rest of the body has been prepped and it's ready to go. So they actually lost very little time of training or intensity or neuromuscular demands. And the first point that I want to make on this, one of the biggest mistakes that physical therapists will make is that they load the athlete too early in those first few weeks. And I would say specifically the 14 days, if not 21 days. And what I mean by that is that if you have an athlete who um, just got hurt and they just got out of the inflammatory phase, they're at the peak of the proliferative phase, and you start to load them a little too soon, their tissue hasn't healed, and you risk sending them all the way back to down to day zero. And if you have a very short timeline where somebody needs to go back to sport at, week 4, if you can't hold them and you can't maintain their progress and you risk a flare up, that 4-week timeline is shot because it was so sensitive that at day 28, you had to be ready to work on plyometrics or return to run. But at week 3, you had to integrate linear based work or multi-directional or lateral based work. And at week 2, you had to develop the strength. And at week 1, you had to work on range. And that's a very critical timeline. And if you have a flare up, now it backs everything up 1 or 2 weeks, and now they have no chance to return to sport. And that's how typically an ortho-based PT approaches it. They're like, well, it's just a new injury. Why don't I just work on it the same way that I would with my ortho case? Well, the problem is that in ortho cases, those people are in remodeling phases. They're in chronic pain. They've already they were at the urgent care 6 weeks ago. They were at the primary care 6 weeks ago, and they finally got x-rays all the way through, and they came to you deconditioned. Now you're right, they might present the same, but the problem is that they've already had 6 weeks of poor scar tissue development, and they're coming to you, and you can be aggressive because it's in a remodeling phase. But when you're in an inflammatory or proliferative phase, it's a very risky timeline. And when you apply remodeling based rehab onto acute injury management, you're going to flare people up. I promise you, and I've seen it 1,000 times by ortho-based physical therapists who only or typically see people only from weeks 4 to years of chronic pain. And the difference is they're remodeling based cases. They already have scar tissue formation. They already have fear avoidance. They already have all of that. When you have an acute inflammatory or proliferative phase, you cannot do that. It's too risky. So if then the question becomes, well, what do? You don't load them early in those phases. You don't load them in the inflammatory phase. You don't load them in the proliferative phase. And if you have to, you wait till day 14 because that's a peak of proliferative healing. Look at any graph, look at anything online, look at whatever you want to look at what happens from a soft tissue healing perspective. At day 14 is this week of proliferation. Now, you ever wonder why stitches come out of post-op cases at day 14, days 10 to 14? Because it's a peak of proliferative. And now it's going to start to scar down. So the surgeons want to remove those things out before they start to form over the stitches. So why don't you use ortho-based PT principles onto acute injuries? That's what I'm saying right now. Do not load them in those first 2 weeks. You're going to mess them up. Do not apply remodeling chronic-based ortho PT onto the first 3 to 4 weeks of care. Complete opposite of what to do. So the question becomes, what else can I add in? That's where the discussion started. So when you're looking at those things, you have to look at, well, what else is there possible? And then what's supported by research and what's good in clinical practice? How do you blend the art and science, blah, blah, blah. Number one, you start have to looking at any topical analgesics that has been supported. I think when you look at research, it grades, there's different grades, right? So there haven't been, randomized controlled trials, but there's been clinical studies and B or C level research that actually has shown that topical analgesics can be effective for pain relief, but not for functional improvement. So that's a big difference to make here. And that's okay, because in theory, all you want to do is decrease inflammation, decrease pain. That allows them to feel better and not continue to walk with antalgic gait, whatever it is. So topical analgesics, something like an over-the-counter that's sold at like Walmart, Target, whatever it is, Voltaren. Voltaren's an easy topical analgesic. Now, it depends on if you're going to go pro-inflammatory or an anti-inflammatory concept. So we talked about the concept of ice versus heat. Right now, things are swaying towards, the direction of, no ice and just go pro-inflammatory. Whatever your case is, just stick with that. So if you're going to go an anti-inflammatory rate, maybe the person doesn't like medication, they don't like they have issues with kidneys, livers, whatever it is. A topical analgesic could be something so nice to allow them have a little pain relief and then bring down their fear avoidance. Another thing we talked about was taping. Taping can be great for short-term benefits. Obviously, for long-term, it's harder to prove, and but it's nice for stabilization. If you look at acute ankle sprains, immobilization is fantastic for them early on. You can do it. There's plenty of meta-analysis and randomized control trials. If immobilization is applied earlier, they have better outcomes longer, meaning they just have a decreased risk of flaring it up again. Now, the ortho-based PT in you would be like, why would you put them in a brace? Because by the time you see them, they're in a remodeling based phase. That's when you're trying to get them out into functional movement so they don't scar down. So you can apply ortho-based remodeling care of brace. I don't brace, I don't tape, I don't blah, 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 because I want to get them stronger. Yeah, but what do you do when you can't touch them for 2 weeks in the inflammatory phase? What do? You have to have other tools in your toolbox. You can't rely on that. I've seen so many ortho-based PTs trying to apply this at a high level with, pro athletes. You don't make it. That's why I don't have ortho PTs in sports-based care, because they're very conservative. They're not progressive. They don't want to tape. They don't want to add in other modalities. They don't want to do the ultrasound. They don't want to do the IFC. They don't want to do the Ionto. And the reason is, yeah, you're right. They might not use long-term benefits. However, they have their place, especially in the acute phases, just to reduce pain, get that motion back, and then you remove them, and then you can do remodeling based care. But it takes you 2 weeks minimum to get you out of that. So topical analgesics, taping, bracing, which is great for mobilization, and then just to feed the sensory input to the brain to be able to like relax a little bit. Somebody with acute low back pain, you put a like a neoprene, sorry, like a Velcro braced neoprene's uh, like belt or wrap. It's fantastic to be able to just give them some sensory input so they can walk around and function, because we want to promote activity. We don't want to promote inactivity. So you don't want to keep people still, especially in the inflammatory phase. You want to keep them moving. However, how do you keep somebody moving if they're in pain? That's why you have to bring down the pain and support with these other things so they can continue doing that and actually increase their healing rate. So we use a couple of those examples, but ultimately, knowing that you have other modalities to help you through those first 14 days, that's the key. Now, if you're out at 4 weeks, that's a whole different approach. That's collagen formation and scar tissue formation. So topicals, uh, bracing, taping, and then any form of modalities that you want, e-stim, all those other things. Now, manual therapy and exercise are great, but you won't be able to do much in those first 14 to 21 days. And that's why you want to have, more arsenal. And so the big mistake that PTs make is that they load too soon in those first 2 weeks because they use the same approach, and you cannot, don't do it. If you want to lose a potential to see a high profile elite athlete, you flare them up once and you won't see them again. I can tell you that. Pro athletes, they see hundreds to thousands of clinicians in their lifespan, and they know that they know when you've not been familiar with something like this. And I've done it. I've been guilty of it. I'm sharing that right now. Don't do it. I thought I came out of my residency and I was like, oh, I've seen people in the clinic, I've seen people in the field. And so I didn't know how to bridge or blend that. And so when I would see an acute ankle sprain and I bring them into the clinic, it was almost like my brain switched. I got inside walls and then I approached with remodeling based care. And then I was outside, I was like a little bit more like acute injury management, and I can be a little bit more aggressive on the field. And then once I brought them in, I don't know what happened. And so learning how to bridge that has nothing to do with the setting that you're in, has to do with what time period you're seeing them. So number one, don't load them too soon or early in the first 2 weeks, especially. So number two, all right, this is a big one. Do not, so the physical therapists do not provide what I call yellow lights. Yellow lights. Okay. So physical therapists are really good at giving green lights. So like uh, you can run. You can jog, you can skip, you can back squat, you can go to the gym 3 times, right? I think we're pretty good at that. Then there's the back end where now you have to give them red lights. Well, I don't want you, no, you can't sprint yet. No uphill work. Your hamstrings flared up, so you can't go intensity above 90%. You can't go back to the gym yet. I know you're going to be tempted. You can't do the treadmill yet. You can't bench press yet. So those are all red lights, right? So you have green lights and red lights. All right. But the reality is the patient or the athlete has this weird like thing we call life in between all those gaps that you just gave them. Can't go to the gym. They can jog, but they can't sprint. And then everything else in life happens to them. They have a 2-year-old son or daughter. They have stairs in their home. They have a dog. They have to walk out. They have to walk regularly. They have a job that's physically demanding. Maybe they're in law enforcement and they have to sprint after people, or they sit in a car. Maybe they're a police officer and they wear a duty belt. You gave red lights and green lights related to their fitness, right? But what you failed to do, and this is, you're probably guilty of this, I did it for the first 2 years, 3 years of my career at least, is you don't provide yellow lights. Meaning, what you have to do is look at their ADLs, right? And let's take 3 easy things: sit, stand, and walk. What modifications or things can aggravate their current condition with sitting, standing, walking? List those out, right? So somebody has a hamstring issue. You don't want them sitting longer than 30 minutes to an hour because you want blood flow in there. Okay. Standing, you don't have any restrictions. Go ahead and stand as much as you want. And walking. I don't want you, if you can avoid hills at any given time, and I don't want you walking at a faster pace than, I don't know, 3.5 on a treadmill or an RPE of 5 out of 10. That's your max. So those are yellow lights for a person in their day. And then you have to look at their work environment. What are yellow lights that you're going to provide them? Oh, if you're in law enforcement, I'd prefer that you will be on desk duty so you don't risk sprinting after anybody. If you work at a desk, just make sure that you're getting up. If you're a student, we definitely don't want you walking across campus for very long, so we'll make sure you try and find a closer parking spot. If you have a scooter, use that. And then you have to look at their fitness. Okay, what can and can they do for fitness? What are your yellow lights? Okay, well, you can jog at 50%. You can't pull, like if you're a barbell athlete or you enjoy working out at the gym, you can't pick up a barbell or weights from the ground. I'd rather have it lifted onto a squat rack or a hack squat, whatever it is. And you're really good at red lights. You're really good at green lights, but the yellow lights seem to be a big problem. If you can narrow down what those yellow lights are for every person that you see that has a very short timeline or acute injury, meaning you got to give the yellow lights for their work, their fitness, and their ADLs. That's where you're going to see the most amount of trauma. Why is this so important? Because people don't get flared up because they went and sprinted after you told them not to. What they got hurt with is they were walking or jogging with their dog. You didn't say don't walk or jog with your dog. I know that sounds really fundamental to you, but it's not their responsibility. It's your responsibility to give them a best outline possible to set them up for success. So if you find yourself having, patients and athletes with flare-ups, it's your fault. You're the person who failed to notify them that they actually have restrictions outside of exercise. Here are your green lights and here's your red lights. Oh my goodness, I forgot to tell you, during your day, which is the most amount of hours that you do, adding more stress to your life, picking up groceries, going up and down stairs, chasing your kids, whatever it is, doing laundry, whatever it is that they do, it's your job to give them a framework so that they actually feel like they have a plan, not just in the gym and out of the gym. And when they see you, there's a whole lot of hours in life that is in between there. So what you need to do is set up people for success using that framework and providing yellow lights. One of the attendees, George, mentioned, they struggled with yellow lights. By the end of it, he was solid. He can pick them out and say, yeah, I got it. All you have to do is in their ADLs, what are they doing? Sitting, standing, walking. Guard those. Provide them yellow lights. And their fitness, give them the yellow lights. And then in their work duties, you give them the yellow lights. If you can do that, you're controlling stress across their whole week, not just the hour they see you or the hour that they're typically in the gym. That's where most physical therapists fail with acute injuries. That's why people get flared up. So next time you tell me, hey, Chris, I had a patient flare up, that was your fault. Unless you gave them all the resources possible and they chose to do that, then it's their fault. Okay. So number one was that physical therapists load too early in the first 2 weeks. Number two, they fail to communicate yellow lights regularly for all domains of that patient's lifestyle. And the last one is my favorite. The last one is where I had attendees admit that this was their problem. So they failed to communicate the entire plan. They failed to outline the plan of care, right? The phrase that stuck with me this week, this was by Andy, an attendee. He said, I said, before this course, how are you managing these type of injuries? And he said, perfectly. He said, well, I never wrote anything down for anybody. It was verbal and it wasn't very detailed. It was just kind of like more red lights and green lights. So it was very generic, right? And the quote that stuck with us was verbal and vague. So if you find yourself with providing, recommendations after somebody's got hurt, maybe it's unfamiliar to you, like, I don't even know how to manage this. I don't want to mess them up, but I don't want to go too aggressive. So if you find yourself being verbal and vague, meaning you don't want to commit to writing it down in front of them because you're like, what if I'm wrong? I don't know what I should write. I mean, what if I forecast wrong? What if I'm wrong? Oh my gosh, they're going to judge me. And what if it's vague because you want to keep it vague because you don't have the confidence, so that way you sound smart. But the problem is that when you're verbal and vague, it only protects you from one session to the next, meaning you still have to face them the next time you come. So that's why physical therapists do it, because they don't really have a plan. So they are the let's see how it goes PT, and they're like, just take it easy. I'll see you on the next session because I don't really have a plan, so I'm just going to make it up as I go. So I'm verbal and vague to help accommodate that. So just in case you aren't going to ask me questions, I'm going to tell you, just come back next session, and we'll cover everything that you need. And when they come, you're like, yeah, next session is where we're going to get all your answers. That's called verbal and vague. So you fail to outline just the plan of care or a detailed outline of really what should happen in theory, right? So if you get a fresh ankle sprain, day one, right? You know that the peak of inflammatory is day 3 all the way into 4 to 6. And you know the peak of proliferative is at day 14 and it goes all the way to day 21 to 24. So you have these peaks and valleys, and then remodeling happens. So all you have to communicate is, listen, in the first week, for sure, the first 3 days, just don't mess this up. Don't irritate it. We're going to immobilize. We'll do strengthening of everything else around it. But in the first 3 days, you are not allowed to do anything directly related to this ankle, right? You're in a boot, you're in crutches, blah, blah. Then at day 14, we're going to start within the first 2 weeks. We'll start some general range, but I don't want you doing any form of weight bearing load for 14 days. Why? Because I think that if you have swelling in there, you're not going to be able to do range of motion. It's going to aggravate it, and you're at risk because we know in this 14 days it's very risky within a healing phase. At week 3 is we start to push it a little bit more because proliferative is starting to tail down and remodeling start to come up, so it's actually getting stronger. So at week 4 is really when we're going to start to load you. And that's why physical therapists can typically load at week 4, because they're coming out of proliferative and into remodeling. If you can apply that and explain that to a patient or an athlete, they're like, oh, I shouldn't mess this up. And then you follow that up with yellow lights and saying, hey, from a fitness level, this is what you can't do. This is what you need to be aware of. And so what I call is you tighten up the bumpers as people go on through this journey. And as you provide those bumpers, they're successful because they're not going peaks and valleys, because you're quality controlling all the stress or the added stress that can be applied to them. And so when you do this, that person has full confidence in you, and you set the plan, or you set the tone from the very beginning. One of the things I can tell people that you should invest in, and Andy had asked this, or they mentioned this is their homework for the next few weeks, obtain a whiteboard. And a whiteboard is nothing fancy. I think I do like an 8x10 or a 10x12, just normal whiteboard that you can buy on Amazon or Target, whatever. And just buy a real quick marker. And every time I have an evaluation, I use a whiteboard, and I just have their subjective, what their targets are, their goals, and then as they tell me, like, well, what do you do for work? What do you do for fitness? What do you do for this? Then I'm already starting to build. What are my yellow lights? Oh, they like running. I see running's gonna be a challenge. You like going to the gym? Gym's gonna be an issue. How many kids do you have? Two. Ah, kids. We have to quality control that. Do you have stairs in your home? Great. So I'm using all their subjective as my yellow lights because by the time that you, at the end of the evaluation, you're going to forget all of that. So the whiteboard, I gave everybody, I distributed a Google Sheet on like a template of like how to design this program and what is essential during that evaluation, so that way you can map this out and help somebody down the line. And a few of those things, if you can just have that on the whiteboard, I have a sports PT checklist where you look at the frequency, intensity, and time of their sport, of their recovery process, what your yellow lights are going to be, and then what they're going to be for their work, fitness, and ADLs, and what's their plan of care look like? What's the frequency? What's their phase of healing? And then you just kind of map this out for 21 to 28 days. And you can do this for remodeling too. That's fine. But here's the hardest part for most physical therapists. They don't want to commit. They're scared of being wrong because you've always been right your whole life. You've done really good things in your life, and you've got through tests which are objective. And when you have uncertainty and you're projecting timelines and healing rates for somebody, you're like, ooh, I don't know about that pressure. I don't want to be wrong. I want to be known as a good therapist. So I'm just going to take it week by week so that way I don't risk being wrong and overcommitting to somebody. That's typically what happens with ortho-based PTs or wannabe sports PTs. So you categorize and find yourself where you're at. And if you're like, I really want to be a fantastic sports PT, that's different than taking a couple courses and learning a couple of great like mobilizations, manipulations, and taping jobs. That's a whole different story. A really good sports PT can make an injury rehab process feel so seamless that they go right back into sport with not a lot of hesitation. The functional outcomes that you have. This was an interesting point. We looked at low back cases. And for acute injury management, when you look at acute low back pain, acute and subacute, they phrase it. Um, One of the best things that when you're looking at this was like the clinical prediction rules or clinical prediction guidelines in 2012. There was an article that came out in 2022 revisiting it, and they gave grades to low back pain treatment. Manual therapy exercise worked best for specific low back pain cases or types, not necessarily for everybody. So you can't do like a thrust manipulation on somebody who's unstable. Most people do better when they're a stiff, mobility restricted person with acute low back pain versus an instability person. They need therapeutic exercise for strength. And I know that sounds really straightforward to you, but when you look at, do you categorize people based on these things? One of the things that they looked at as one of the best ways that functional outcomes are improved by is the person's belief that they actually are going to get better. So you can do all the exercise, all the manual therapy, have the fanciest brace, the greatest exercise, whatever it is that you have, the analgesic, the taping. If they did not believe that they had a plan or they were going to get better, their functional outcomes worsened. So in order to improve your outcomes, that person has to feel it and believe it. If you don't do that, none of your exercises work. So one of the best things you have to do is develop that relationship and get that buy-in. That person has to buy in to what you're doing. And if you don't have a plan or projection, you don't give them yellow lights, and you load too soon, they lose all confidence in you. And I think that's the most important thing to take away is, can you help somebody believe that they're going to get better? Now they have to have some form of optimism. I get that. They have to be in it. I get that. But if you have somebody who's chronic pain, it's a whole different world. They're already too late. They're in the remodeling based phase. They lost. And so low back pain, acute low back pain prognosis is better when that person feels that they have a plan and they're going to get better. They have to believe in that. So all you can do is accommodate that. So now let me rephrase this, and I brought this up at the beginning. What's the difference between an ortho-based PT who doesn't know how to manage acute injuries and can flare them up and can't get a patient buy-in compared to an urgent care or primary care who says rest for 4 weeks, rest for 2 weeks? So the person went to an ortho-based PT and loaded too soon, didn't give yellow lights, and couldn't create an outline, flared the person up, or did no better than an urgent care, who would have said just rest for 4 weeks. At least at that point, they're just swollen, stiff, and but not in increased pain. They're just not doing great. Or a primary care physician who gives them meds, tells them to, just wait for 4 to 6 weeks to go CPT, and that person's still in the same condition when they come out to CPT. They're just slowly, like, maybe getting better. But an ortho-based PT would risk flaring them up, applying remodeling-based care onto acute management, worst thing to do, would not recommend modalities, taping, analgesics, and a positive mindset. Why? Because it's not typically needed in the ortho-based setting. They want to get functional outcomes, so they do 57 exercises and maybe a little bit of manual because that's the thing that gets people better. Or you learn to distinguish the difference between remodeling-based care, chronic pain, and acute injury management. Two different worlds. You can't do a lot of manual and Therex or therapeutic exercise in the acute phases. So what else you have to do? You have to create the platform underneath. You build a strengthening program around the joint. You let them go back to fitness, get on the bike, get on the rower, get on the skier, get on something so you can keep your fitness. Maintain a positive mindset, go to practices, engage with the team, but you are not allowed to touch the basketball, be on the court, whatever it is. That way, mentally, they're still in it. They have a positive mindset and they're ready to go back to sport. They've been working on their fitness. They've been working on the strength, everything around that. They've been having immobilization so they don't flare it up or somebody else doesn't trip them. And they have tape to help with fluid reduction, swelling reduction, and overall pain relief. When you have all those things underneath those first 2 to 3 weeks, you didn't flare up the ankle, but the rest of the body was ready to perform when the healing phase matches. So as an ortho-based PT, you don't necessarily spend time on the injury site. You create the plan so you have a well-rounded approach to any given athlete who happens to have an acute injury. So our ortho-based PTs who have a remodeling-based approach in acute injury management any better than an urgent care or primary care? I put them all at the same rate, unless they know how to manage this appropriately. So if you're a sports physical therapist and you want to learn how to do this, you have to use some of these principles. Yellow lights, give them the full outline, and just commit to something. Get yourself a whiteboard and start writing things down with that patient or that athlete to set them up for success. And the last thing there is just don't load them early. Don't be fancy. Don't be that like too many exercises PT. Don't do the darn thing. So that's what I took away from the accelerator. Having good conversations with everybody. I'll continue to share these down, and the next phase that I'm moving all these physical therapists into is they can manage the acute injury management side. They don't have to be a remodeling based PT. Now the next step is how do you get them? How do you work on their strength and conditioning while they're in acute injury, while they're in a rehab or remodeling based phase, or while they're in sport and not injured? This is a whole different section of sports PT that most CEU courses, most education courses, most PT schools won't even cover, because it has nothing to do with the quality of life or ADLs. It's about how do you create strength programs, true strength programs, not like 2 sets of 10 for 3 sets of 15, and then you think you're running a strength program, but all you're doing is adding more sets, more reps, more load until they tell you they're feeling better, and then you let them go. That has nothing to do with that. I'm talking about planning out a true strengthening program for a mesocycle, a microcycle, whatever they have in season, out of season, off season, peak, post season. And if they're hurt, how do you change parameters? What intensity? Or if you're going to do a back squat, what is that load? How are you going to modify that? What percent should they be in season? 50 to 93%. What should they be in off season? 50 to 75%. Their intensity changes. What should you do? How are you running their energy system demands? Are you doing aerobic based endurance off season or post season, or are you doing interval based anaerobic work in season? It gets very messy if you can't create a process so that when you get athletes on your table, you know how to run acute injury with a foundation of strength and conditioning programs underneath that. That's my next course. That's what I'm doing next with sports PTs. I have an upcoming course called the Strengthening Sports PT Strength and Conditioning Summit, where I show sports PTs like yourself had a program. If somebody's in season, are you working on explosive strength? How do you work on strength endurance? I mean, there's multiple layers on how to create a really good program, and it has nothing to do with exercise bands, nothing to do with clamshells, nothing to do with core activation, nothing to do with hamstring length. This is about setting the tone and working with strength and conditioning professionals to be able to support athletes developing a base level of neuromuscular control, endurance, hypertrophy, strength, and power all season long to help them be able to be successful in their sport, not just rehab and injury. So I created it because I've worked with so many strength coaches all over the planet, some of the best in the country and the best in the world. And I learned the fundamentals. And there's a way that sports physical therapists can blend this into clinical care, whether you're in an ortho-based setting, you work in pro sports or collegiate. You just need to learn how to communicate with patients and athletes, communicate with strength coaches, communicate with just general coaches, whether it's football coaches, basketball coaches, and it puts you in a really good position to be able to talk the talk, not just walk the clinical walk. And so, if that's for you, uh, go ahead and go onto my website, drchrisgarcia.com/summit. That is being hosted June 17th and 18th of 2023, whenever you're listening to this. So I am hosting that virtual and live. That was a big one. I've had so many people register online that it surprised me. So I now have two options to be able to sign up for this course. There's a virtual option only, and there's in person. So choose whatever works for you. In either case, I'm excited to be able to help people all over the country and all over the world. Just change your clinical reasoning, your mindset, give you more tools in your toolbox. So I'm excited for that and be able to help you into the next phase of your career. So that's all I have for acute injury management. Don't do those three big mistakes. Don't do it. Just take it easy, but have a plan and a solid foundation underneath everything. Don't do anything for the first 3 days, 14 days, 21 days. Once you're at 28, have fun. All right. I hope that helps. I hope you guys are doing amazing and enjoying life and loving every minute of it. All right. I will see you guys on the next episode. Take care.